Good day. My name is Christian Benedict for Medicine 1, St. Carol School of Nursing. This is lesson 4. In this lesson, we are going to be talking about fluid electrolytes as well as fluid balance and how it's affected physiologically and anatomically in the body. In this lesson, we are going to be talking about fluid electrolytes and fluid balance, how it affects the body physiologically and anatomically. From our anatomy lectures, we know that the total blood volume of a healthy individual in a normal state is 7 to 8% of his normal body weight. We also remember from anatomy that 30 to about 45% of the blood is hematocrits. And hematocrits refers to the red blood cells, the white blood cells, and the blood platelets. The remaining 55% consists of blood plasma. Blood plasma refers to electrolytes and fluid which have been dissolved, electrolytes which have been dissolved in fluid, which is called serum, and clotting factors. When plasma is left to settle, what forms on top, like every other wound healing or when there's bleeding, what forms at the surface is a clot. And the clotting factors activate a blood clot. When plasma is allowed to settle, the clotting factors form on top and the serum is left below. We will also remember that 66% of your total body weight is fluid. That means that if 8% of your total body weight is blood and 66% of your total body weight is fluid, then there are spaces outside the vascular structure that contains lots of fluid. There are spaces outside the normal vascular structure that constitute part of body fluid, which forms a huge chunk of your waist. And that is what today's lecture will be looking at. As stated, plasma contains serum and clotting factors, and serum consists of electrolytes, proteins, cholesterol, and all other molecules necessary for body function, dissolved for the use of the blood, like glucose, waste materials, carbon dioxide, etc. For the purpose of this lesson, the most common electrolytes dissolved in serum are potassium, calcium, magnesium, and phosphorus. Other electrolytes dissolved in serum are sodium, copper, zinc, vitamins, etc. However, for the sake of this lesson, we will be discussing only these 4. Potassium. Potassium has a normal range of 3.5 to 4.5 or 5 milliequivalents per liter. In combination with other minerals in the body, potassium forms other salts that are important for body processes. Potassium is chiefly needed for depolarization in the heart during contraction and expansion. Potassium is abundant in cardiac muscle and smooth muscle, but may also be present in skeletal muscle. As stated, potassium is responsible for muscle contraction in the heart. Potassium may also contribute to electrolyte balance in cases of alkalosis. Potassium is also needed for nerve impulses. pH balance is inferred in electrolyte balance. Heart rhythm is inferred in muscle contraction. And also, due to the presence of potassium in smooth muscles. Potassium aids in digestion. Most foods we eat contains potassium. Hence, hypokalemia is highly unlikely from dietary or poor dietary intake. However, a person can get hypokalemia as a result of unbalanced diet in rare instances. Dietary intake on a daily basis contains about 50 to 150 milliequivalents per liter of potassium, and that is why dietary intake cannot necessitate hypokalemia. One has to remember that the normal potassium level in the body is about 3.5 to 4.5 milliequivalents per liter, and that is what is needed for the body, and hence it is not necessarily every potassium that is taken in dietarily that is used by the body. Most of it is excreted. In the kidneys, when it comes to tubular reabsorption, about 60% or 68% of potassium is reabsorbed at the proximal convoluted tubules. The loop of Henle takes about 12%. And when the body has excesses, there's secretion at the distal convoluted tubules, and that results in the balancing of the potassium we have in the body. You have to bear these in mind as you come to identifying hypokalemia and hyperkalemia. Potassium is mostly abundant within the cell or in intracellular compartments as opposed to extracellular compartments. And as such, it is highly unlikely to find potassium in extracellular compartments. When potassium enters serum or enters the bloodstream, it is most likely going to be excreted out of the cell. In rare cases where there is alkalosis, metabolic alkalosis, potassium comes out of the cell to help balance the alkaline nature of the blood due to its positive charge. Where alkalosis is implicated and potassium within the cell is highly depleted, when corrected, insulin is responsible for putting the potassium back into the cell for cellular use or for cellular function. Hypokalemia. Hypokalemia is a condition that is caused when potassium levels within the bloodstream is less than 3.5 milliequivalents per liter. You would have to note that if a question is given, hypokalemia would show by a very large difference. I'm trying to say that in an exam, when they want you to identify hypokalemia, they will not give you a value of 3 or between 3 and 3.5. They will give you something less than 3. So something, say, 2.5 or 2.8 for you to identify hypokalemia. Remember that potassium has a very low therapeutic index. That means that potassium acetate cannot be contained in high amounts. Deviations within the body, deviations have to be very minor and not too large for either hypokalemia or hyperkalemia, else it may result in abnormal heart rhythm and the patient can easily die. Possible causes of hypokalemia may be excessive use of cortisone or corticosteroids, excessive alcohol intake, which will lead to alkalosis and result in hypokalemia. Unconsciousness may also result in hypokalemia. In unconsciousness, one has to remember that most of the potassium that goes into the body enters the body through dietary intake, about 50 to 150 milliequivalents per liter. In unconsciousness, where diet does not consider potassium intake. A client may easily get hypokalemia. Unconsciousness. One has to remember that most of the potassium that goes into the body goes in as a result of dietary intake, about 50 to 150 milliequivalents per liter. In unconsciousness, food served does not include potassium on a regular basis. As such, nurses have to include potassium chloride into IV fluids to ensure that potassium remains in the patient's blood. Excessive insulin intake or excessive insulin or diabetes may also result in hypokalemia. Although insulin is chiefly responsible for putting potassium back into cells, where there is excesses, the body has to balance itself. And the body balancing itself means that potassium may easily leak out of the cell and be excreted as a result of excess insulin. Kidney problems or prolonged use of diuretics, what is commonly known as water pills, may also result in hypokalemia. During metabolic alkalosis, as previously stated, may result in hypokalemia. And from iatrogenic causes refers to causes of disease that are resulted from medical treatment or medical therapy. Iatrogenic causes like prolonged use of beta agonist or alpha antagonist may result in hypokalemia. You will learn more about this as you do your pharmacology lectures. In hypokalemia, as has already been discussed in the functions of potassium, you will note that when there's hypo, all these functions tend to go in retrogress. As such, you would have arrhythmias, muscle stiffness, resulting in rhabdomyolysis. Rhabdomyolysis refers to the breakdown of protein, excessive breakdown of protein. And as such, the kidneys will have to excrete these proteins rapidly and can easily lead to kidney failure. This is a medical emergency and must be treated as an emergency, and hence hypokalemia is a serious condition that we will always want to prevent at all costs. Persistent numbness of extremities may also occur in hypokalemia. Mood changes as a result of the dopamine implication in the use of potassium. A client may experience high anxieties or severe mood changes when he or she has hypokalemia. A client may also experience muscle weakness. As has already been discussed, potassium is chiefly abundant in skeletal muscle, in smooth muscle, and in cardiac muscle. When potassium is no longer present in skeletal muscle or in smooth muscle, a client will experience some form of weakness in the muscles. Potassium also aids in digestion, and as such, when potassium is not present, a client may have complications such as bloating and constipation. Bradycardia, as you are well aware from your anatomy lectures, the sodium-potassium pump in the heart ensures that potassium causes depolarization and sodium and calcium lead to polarization. The lack of potassium may result in inability of the heart to contract, and the inability of the heart to contract will influence bradycardia. And so one has to note this as implicated in hypokalemia. Lab investigations will show prolonged QT waves and appearance of a U wave at the T section of the ECG. Lab investigations may also reveal a low level of potassium within the bloodstream. Atrial arrhythmias and ventricular arrhythmias may also be implicated where there is low potassium level. In the management of hypokalemia, it is necessary to treat the underlying cause. Treating vomiting and diarrhea may be necessary in the management of hypokalemia.